He's 48 years old male patient with type 2 diabetes, controlled on glimepiride 3 mg per day. He has history of mild hypertension, hyperlipidemia, with long-standing alcohol intake abuse. He complains of fatigue, malaise, and lethargy, which have been progressive over several months. The patient is on no other medications. Examination shows no abnormalities. Investigation shows conjugated hyperbilirubinemia, normal liver function test, high alkaline phosphatase. This denotes that there is cholestasis, of course. Okay, ultrasound is completely normal. So, in such case, your initial approach and decision for such patient is, number one, this is alcohol-induced and advise him to stop alcohol, or it is NASH and advise him to lose weight. Number C, this drug-induced and shift to other oral hypoglycemic. This is drug-induced and shift to insulin, or start workup for investigations for liver injury not related to diabetes. Anyone from the floor wanted to comment, or we will go to our panel? Okay, Professor Vaz?
I would say A, it is alcoholic induced, and I would advise him to stop alcohol, but on the other hand, I would do either, I would do an ultrasound, might be he has gallstones too.
Normal, ultrasound.
No, it was normal. So I would say him to stop alcohol, I think.
But he is showing cholestasis. He is showing cholestasis, high gamma GT.
What I didn't
yes,
understand.
and liver functions are normal. Liver functions are normal.
Liver functions are normal.
Okay, Professor Eckert.
As far as I caught this, is isolated hyperbilirubinemia, correct, right? So AST and ALT mean by liver function?
Normal.
Okay. And the other national function tests, such as coagulation profile, were also okay, also normal?
No, it's not reported here, but it was normal.
So the AST and ALT being in the normal range speaks against alcohol injury. And it's possible that, I mean, he probably has underlying alcohol liver disease, no question about that. But the question is, why is it compensating with the liver now? It could be drug induced in this case as well. So, you need to think about this could be from the drug and you might want to change it. NASH is the same thing. You would expect a different profile of the liver enzymes. It's
absolutely
pretty normal. It's very unlikely. So it's an unusual presentation. I think you have to underline alcohol liver disease. Maybe the question is how long did you take the drug for? Maybe it's important to see if it's related to that, or if you took anything else.
So you like to, or you recommend to stop alcohol and to continue the same oral, or to change to other oral? Maybe if there is possibility also for, because glimepiride can cause cholestatic jaundice as well, or cholestasis.
I would change to another oral antidiabetic. For example, DPP-4 inhibitors could be given in hepatic problems, or metformin could be in this case. But I wouldn't put him on insulin. If he drinks alcohol and insulin, it's pretty dangerous. I wouldn't dare it.
Okay, so I think the message is clear that not every hepatic patient should be on insulin. He can be treated with oral medications, right? Some of them are safe.
In this case, he has no elevated liver enzymes, so
you can continue. Okay, thank you very much.
One question, please. If this patient refuses to stop alcohol and he is insisting in alcohol intake, and do you change to the oral treatment in a different way, or you have to hospitalize or isolate the patient and treat him as if he is ruining his life? What kind of, if you refuse to stop alcohol?
That's a normal, that's everyday life. He doesn't want to.
I think it's not that easy just to take the patient, stop alcohol, and say, okay, doctor, I will stop alcohol next day. No.
No.
Should the patient?
No, I mean, he can hospitalize the patient, you can put the patient,
He will go out, he will start having alcohol, and he will have alcohol while he is in the hospital.
Yes, exactly like cigarettes.
Yeah. Thank you. Any more comments about this case?
This patient who has normal liver enzymes, the only problem with the hyperglobin, which is conjugated.
And the gamma GT and alkaline phosphatase also are high.
Yes, this is obstructed patient. And although ultrasound is normal, this doesn't mean that we have to exclude all surgical causes like head and cholangiocarcinoma that's not yet clear or mastostome. I think this patient needs to be investigated because if even the drug was responsible for these cholestatic joints, liver enzymes, mostly treatments with hyperbilirubinemia. It's very unlikely to have just hyperbilirubinemia alone due to drug. Other enzymes should increase with it. I don't mean should likely to increase with it. So I think that this patient needs a lot of investigation. Like CT, like MRCP.
Yeah.
I may think like that.
Okay, this is another point. Okay, your opinion, Professor Eckert?
I do agree that that we should be worked up for other possible reasons, and that's why I also said maybe we should check how long he's been on the drug for. But what I don't agree with is that they always have to have all of the enzymes go up. We know that there's a cholestatic type picture, there's a transaminitis type picture in some drugs, and some have a combined picture. So you can have isolated hyperbilirubinemia and gamma GT elevation with the AP being elevated and not the AST and ALT. That depends on the drug. There's a nice review on this in the New England Journal a couple of years back that discriminates which drug falls into which category. I have to look it up myself which one is which. It does happen.
Thank you. We'll move to the last case, and then Dr. Bass will present your case.